This is Professor Ariel Ortiz Lagarde streaming live from the International Bariatric Club studios at the International Institute of Metabolic Medicine in Baja, Mexico. The theme of today's IBC Oxford University Hot Topics in Bariatric Surgery exclusive event is how to get trained in endoscopic sleeve gastroplasty, and will feature experts from the United States, the United Kingdom, South Africa, Germany, Saudi Arabia, France, Brazil, and Mexico. The IBC University of Oxford webinar partnership would like to thank Zoom Video Communications based in California, Laparoscopic Surge based in Tunisia, and Bariatric News based in the United Kingdom for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, Ethicon Endosurgery, Mindray, Easy Surge Medical, our gold sponsors, David Medical, Medtronic, Lexington Medical, Reach Surgical, Stryker, Blue Sail Surgical, our silver sponsors, Apollo Endosurgery, GT Metabolic Solutions, USGI Medical, our bronze sponsors, Arthrex, ConMed. This is the 83rd webinar of the IBC Oxford Academic Series that is streaming live globally to viewers through the IBC website, ibcclub.org, the IBC YouTube channel, via Facebook Live to the IBC Facebook page, the IBC Instagram, and Twitter. The IBC Oxford webinars are organized by Professor Juarez Cuaja, consultant bariatric surgeon and director of the IBC Oxford Education, based at Chelsea and Westminster Hospital and Imperial College, and London Christchurch Oxford University, and Mr. Bruno Sgromo, consultant bariatric surgeon and co-director of the IBC Oxford Education, based at John Radcliffe Hospital, University of Oxford, UK. This event will be chaired by Professor Reem Sharaya from the United States and Mr. Bruno Sgromo from the United Kingdom, and will be moderated by Professor Christine Stier from Germany and Professor Ayed Al-Katani from Saudi Arabia and Dr. Everett Asanti from South Africa. My chairs today are Professor Reem Sharai from the United States and Mr. Bruno Sgromo from the United Kingdom. Professor Sharai is Associate Professor of Medicine and Director of Interventional Therapeutic Endoscopic and Bariatric and Metabolic Endoscopy, Weill Cornell Medical College of Cornell University in the United States. Mr. Bruno Sgromo is Clinical Lead Bariatric Surgery at the Oxford Radcliffe NHS Trust, University of Oxford, UK, co-founder and co-director of IBC Oxford University World Congress and co-director of IBC Oxford University webinars. I will now ask Professor Sharaya to introduce our moderators.
Good evening, everybody. I'm jumping in for Professor Sharaya. So it is really my big honor to introduce you the moderators, which is the highly esteemed Professor Ayed Al-Katami from Saudi Arabia, who is a consultant in minimal invasive and obesity surgery at King Saud University and the director of King Saud University Obesity Chair in Riyadh, Saudi Arabia. And he's the president of the Saudi Arabian Society of Metabolic and Bariatric Surgery. Good evening, Professor Al-Katami. And it is my honor to present Dr. Everett Asante from South Africa, who is a specialist surgeon and bariatric endoscopist. He is working at the Cefaco, I hope I pronounced this right, Magato Health Science University at Johannesburg, South Africa. He's a specialist surgeon in Medical Center, Johannesburg, South Africa. Good evening, both of you.
Good evening. Thank you for having us.
Good evening, Steer. Thank you so much, and glad to be with you here today, all of you.
So it is also my honor to present the first speaker, who is the well-known and very famous Professor Christopher Thompson from the USA. And he will give us a speech about not all ESGs are the same, the good, the bad, and the ugly, and the importance of training. And Chris, I really have to read your affiliations. I don't know them in my mind. So Professor Christopher Thompson is Director of Endoscopy and Co-Director of Center for Weight Management and Wellness at Brigham's and Women's Hospital at Harvard University in the USA. He's Professor of Medicine at the Harvard Medical School. He's founding member and former chair in Association of Bariatric Endoscopy, and he's a founding member of IFSU Bariatric Endoscopy team and a governing board member of the American Society of Gastroendoscopy. So thank you, Chris, that you're with us, and I'm really curious to hear your talk.
Thanks very much for the kind introduction, Christine, and I'm excited to speak on this topic. So I will start by sharing my screen here. And you see it?
Yes.
All right, perfect. So, well, we're starting here. And I think first it's important to note that ESG is not the same as an intragastric balloon placement, right? It's just very different. So for people just starting to get interested in this, there's a lot more going on with an ESG. There's a lot of steps in suturing. You have to understand the device and the procedure. And this is a scene you can get into with ESG. You know, if you have a device issue, you'll have wire cutters and pliers and all sorts of equipment trying to solve that problem. So things you just don't get into with intragastric balloons. And so the topic I was given was the good, the bad, and the ugly. And I had to look that up. That's a movie from 1967. It's a spaghetti Western that was directed by Sergio Leone, and quite an interesting movie. I checked it out. Something worth recommending. At least what here is the good. So anyway, I'm going to start by doing ESG background, and then I'll touch on the good, which is sound technical principles and expected clinical outcomes, and we'll review some of the literature there. We'll then get on to the bad, which is technical errors, device malfunctions, and troubleshooting. And then, of course, the ugly, which are adverse event identification and management. And we'll start with some background. So, you know, back in the day, in the early 2000s, we had this suturing device that we could use to treat GERD and some other devices that were coming about. And there were two competing ideas. One was to recreate the vertical banded gastroplasty, which Roberto Fogel was doing here with his procedure, and the Toga device did. And then, and this actually got some pretty decent results. And then there was the idea of replicating the gastric imbrication procedure, which was really at the time being performed more in South America. So I was working on that procedure, and with the Cleveland Clinic group. So what we did was use a newer version of the EndoCinch device to actually work on that greater curvature. And we were using a series of running sutures, which is actually very similar to the current ESG procedure. And we call this the trim procedure. And we studied 18 subjects, had a 27.7% excess weight loss, which was, we thought was encouraging, with improvement in waist circumference and, you know, blood pressure and whatnot. There were no adverse events. However, and look how beautiful that looks at the end, right? That's a beautiful looking sleeve, just like an ESG. However, a few plications were left intact at 1 year because of the partial thickness nature of the suturing, and the company abandoned the project. Fortunately, in 2012, we had the second generation of the OverStitch device, and we had the honor of doing the first in human studies, myself and Rob Hawes in India, where we did you know, a very similar pattern to that trim, and you know, working again specifically on the greater curvature, trying to make the stomach kind of reduce the width and the length of the stomach with these stitches. And we got some good results. We studied 126 patients. Those initial ones were in India. We then spread to Panama and Dominican Republic, and we grew the team, as you can see here. And we saw an improvement in BMI from 36.2 down to 29.8, and just above a 19% total weight loss at 1 year in this initial group. That was very encouraging. So what about the good? Moving on to technical principles and some clinical outcomes. Well, what makes an ESG good? I'm going to show you here on the right is an ESG from Sai when she was my fellow. This is, I think, one of her final ESGs. And this, I think, shows very good technique. And you'll see she's getting good full thickness bites. The stitches are close together, and we'll talk about this. So you can watch that as I go through some of the principles here. But so sound technique is what makes an ESG good. You want to use a proven pattern. There's a lot of patterns out there, just make sure you're using one that actually is known to work. Don't just throw random stitches in the stomach. It's not the way to do it. An adequate number of sutures and stitches is also required. If the pattern you're using uses 5 sutures or 8 sutures, don't just put in 2 or 3 thinking it's going to have the same effect. Full thickness stitch placement is critical. That's why we're using a helix here to grab that and pull it in. You want to make sure you get enough. You want to rotate the device a little to the left to get that in position. Now we're using a Fuji scope here, so we don't have to rotate quite as much. It's kind of set up in the ideal position. And then you want your final appearance to look like a tight sleeve-like anatomy, which you'll see here at the end. The procedure duration should be about 40 minutes up to an hour and a half. You shouldn't be taking 2 hours to do these, right? Maybe early on in your learning curve. And you shouldn't be doing them in 20 minutes unless you've done a couple thousand and you're really moving along well, but it's rare to be able to do them in under 40 minutes. You want no unforced errors. Don't drop needles, bend needles, break sutures, break cinches, lose sutures, have loose sutures or knots. You want to avoid that stuff. It's going to slow the procedure down and it's going to lead to complications. You need troubleshooting expertise because even if you do your best, devices will break and you'll need to know how to fix it. This is the final appearance. That's a beautiful tight sleeve. That's what we're going for, right? That's what you want. The patient should be comfortable and able to go home. And you should definitely achieve the expected weight loss with rare SAEs. So that's what makes an ESG good. And again, the final appearance there. So what about the expected outcomes? This is a study by Reem Shariah, and this was a prospective series studying 91 patients up to 24 months of follow-up. And she found a 20.9% total weight loss at 24 months, which was great, with an SAE rate of 1.1% and 1 perigastric leak. This is what we're aiming for, right? She also found improvement in comorbid illness, with improvement in HbA1c of about 1 point, improvement in blood pressure, triglycerides, and liver tests. She also followed patients out for 5 years. This is 216 patients. And you can see here the 82% follow-up rate at 5 years, which is good. That's only looking at 68 patients, but still good. And this found a 15.9% total weight loss at 5 years, with 90% of these patients maintaining at least 5% total weight loss and 61% maintaining 10% total weight loss. Some patients, a minority, were on some pharmacotherapy. And again, the SAE rate was 1.3%. What about groups earlier in their learning curve? You know, do you have to do this for 2, 3, 5 years to get these results? This is a study that I participated in with several Brazilian groups, and with 7 centers with varying experience. We studied 193 patients, and now we're using a U-stitch pattern. So the original pattern was sort of a double triangle pattern, in this case, we started doing these U-stitches, as you can see on the right. And what we found is a 15% total weight loss, and that was at 12 months, and that was uniform across centers. Even though some centers were kind of early in their experience, they didn't have a couple hundred cases, they were doing quite well also. All centers had at least 10% total weight loss and a 25% excess weight loss. We found predictors of success to be younger age, male sex, and a higher BMI, which was also something that was new. So we thought, oh, this won't work if BMI is over 40, where in fact it does. And these people do lose more weight. And again, about a 1% SAE rate. Now we have the big study by Al-Khatani here, 1,000 patients, right? Again, he looks at efficacy, and we're getting right in the same area here, 15% at 12 months and about 15% again at 18 months. SAE rate about 2%, right in the range. What he found is you can reverse these. That's another added benefit, right? If you needed to, if someone was really uncomfortable, you can go and cut those sutures out. And he also studied the pediatric population. So lots of new learning there, and it looked favorable compared to laparoscopic sleeve. And here is the meta-analysis pulling this all together. Many of us involved in this. 8 studies, 1,772 patients. Efficacy, 16.5% total weight loss. SAE rate, 2%. And, we'll get into these, but, nausea, bleeding, perigastric leaks, things you're going to be looking for. And this is what we're aiming for a good ESG. These are the numbers we should achieve. And finally, we have the MERIT study, the big multi-center prospective randomized control trial 209 patients randomized to ESG or a lifestyle modification arm. And you can see here, percent total weight loss, only 13.6%. Now, this is lower than all the other stuff I've shown you and lower than what you see in the literature because this was done during COVID. So people couldn't go to the gym, they couldn't buy healthy foods, they have a little bit less weight loss. But nevertheless, it is level 1 evidence and it supported the FDA granting de novo marketing authorization. So that's the good. What about the bad? So technical errors and malfunctions and whatnot. So there's a lot of things that can go wrong when you're suturing, right? You can have needle-related issues, suture-related issues, helix problems, and cinch-related issues. This is a topic of a whole different talk that I have. I just pulled a few slides out to show you kind of what you can get into and how to troubleshoot. And these complications are brought to you by our endoscopy fellows. They certainly have contributed to many of these little problems, and we thank them for it. So the first one we have here is, you can see suturing device in place, but the suture is wrapped up around the tower. So it is kind of trapped here. So that's something you run into, when you have too much suture slack. So you want to keep that trimmed when you're working. You don't want to have a lot of suture floating around down in there. So, how you get out of this is you pass the needle back to the pickup, okay, or the anchor exchange. You wiggle a little, turn the device to the right, you'll go clockwise with it, and then generally you can get out of it and pull out. But you want to notice that early before it causes a problem, and definitely before cinching. Critical to know, or you're getting into worse problems. Here's another one. So here you saw we cinched, but see this metal wire coming out of the cinch. The cinch never released, okay? So you cannot pull the device out of the channel. The cinch didn't release there. That's a problem. And usually it's due to the assistant not straightening the device, and then it breaks the wire inside. So here you see step 1 of cinching, you lock the suture. Step 2, this is that wire. It's supposed to pull out of the cinch, releasing it. And then the second part of that step is to cut the suture. Okay, but this little wire never was released. So how do you get out of that situation? You have to cut through the handle, and then you cut through the wire, you pull out this coil, and then you grab this inner wire right here, which runs all the way down. There's another coil wire here, runs all the way down to the cinch. You just got to pull quite aggressively on that, and it will release. Again, something you really do need to know, and something that adds to the complexity of the procedure. So make sure they keep that cinch straight when they're cinching, and do it nice and slow. Okay, here's another one. We're again cinching again, and looks like it goes okay, but when you insufflate, it starts opening up, right? Ooh, it releases. Okay, that's a problem, right? So the suture break or cut before cinching. It can be due to a frayed suture. Okay, so make sure as you're going, you watch the proline. If it gets nicked, it becomes weak. So you want to make sure it's not rubbing on a metal part of the device. That can be an issue. All right. It can also happen when that second step of cinching occurs too quickly. All right. So that's, you're doing step 1 and step 2 too abruptly. And so you don't ever really lock the suture in place. So there's different ways this can happen. And how you prevent it is you pre-tighten. You want to, after you suture, we're showing it here, you pre-tighten. Okay, make sure you, and Manuel Galvo is a big proponent of this, and this really does reduce this problem. Keep this cinching device straight again and provide counter pressure, but have it be gentle. You don't want this to come all the way up into the channel. And then if it does happen, you've got to remove that suture, because you don't want the suture going through a few folds of tissue. That's going to lead to a leak. You want to find that little needle or the T-tag, grab it and remove it, and then suture over exactly, kind of try to go close to where you were to close those little holes off. So that's the bad. What about the ugly? So these are adverse events and how we identify and manage them. So there's several things to worry about: acute perforations, leaks, bleeding either in the stomach or intra-abdominally, intramural hematomas, stenosis, and PE DVTs. Now, we don't have time to cover all these in this brief lecture. I'm going to cover a couple of more concerning ones. One is a perforation. Now, I've never had a perforation during ESG, fortunately, and knock on wood there, but I've had it for other things. You see, this is a big perf. You can watch the video on how we treat it, right? We're going to go out into the abdomen, look for any contamination. We put a Varus needle in or an angiocath to evacuate it and control it. We're then going to back out And if it's not soiling or any problems out there, no big bleeding, we'll come in and close the hole. You have a suturing device, you might as well use it to close the hole, right? And in this case, we're actually pulling the omentum in to kind of do a little gram patch as well. So with perforations, usually they're small, okay? And it's important to have early detection. You want to do frequent abdominal exams during your ESG and feel for crepitus. Okay, additionally, have anesthesia monitor for end-tidal CO2 and peak airway pressure, because if this end-tidal CO2 is going up too high, right, if it's above 45, you know that can be a problem as well. And additionally, if your peak pressures are above 30, then you need to really get out and decompress the abdomen. You can still continue usually, you just have to address the perforation. Leaks, you know, here's an example of a leak. Again, this wasn't during an ESG for me, but it was after another endoscopic bariatric procedure. And, you know, it's hard to diagnose these sometimes. They can present without fever or leukocytosis or even pain. Tachycardia is the most kind of earliest and most common thing that you will see, just like with surgical leaks. Upper GIs aren't terribly sensitive. Methylene blue swallows are great if you have a drain in place, but you usually don't put a drain in after an ESG. So really look for tachycardia and an elevated C-reactive protein. And then you treat it with a drain. But, you know, the key is, how do you avoid leaks? And you can avoid leaks because, you know, suturing the fundus is the primary reason people get leaks. It's very thin up there. They put too much tension on that suture when they're cinching it, and it necroses through and you develop a leak, okay? And you can also just run into problems up in that area. So avoid suturing the fundus. Avoid needle passes without effective pickup. Sometimes it's not aligned well, and if you keep going back and forth in the same spot with a needle without picking up the needle from the needle driver, you're going to potentially have a leak there, especially if you're up near the fundus. You don't want to pass the needle driver through tissue without the needle on it. It's blunt. That can cause problems. Keep the needle driver in tissue for long periods of time can cause a problem, especially if you're moving around. You want to just kind of advance it through the tissue, pick up the needle, and then open the device up. Pulling the helix directly out of tissue can be a problem, and suture loss. If you don't pull the suture out, you can also be left with a leak. So if you don't do these things, you're far less likely to have a leak. And finally, stenosis. So, you know, if you get a stenosis early in your experience, congratulations, because, you know, you're doing something right. You're doing it a little too right. So, you know, you want to make sure that you don't suture too close to the lesser curve. This could be due to an intramural hematoma, so be aware of that. You want to not be too greedy there. And then, of course, if you need to treat it, you can put a little NJ feeding tube down. And if it's, you know, if you're 6 weeks out, you can be more aggressive with balloon dilation and cutting and removing sutures as well. And that's just what the balloons look like. So in conclusion, ESG is harder than it looks. You've gotta respect it and take it seriously. Avoid unforced errors, and that's essential to being fast and doing these procedures efficiently and well. Troubleshooting is an important skill to have. It does come with experience, but there's a lot you can learn from videos and courses. And adequate training is critical to success, and that's what we're going to hear about for the rest of this conference. So thank you very much for your attention.
Excellent, Chris. Great talk, and thank you so much for this very nice demonstration from the start to the end into troubleshooting, and show how much experience you have and also how many people have learned in your hand. Now, if you were asked, Chris, to put a protocol for somebody listening to us today to learn ESG from dry lab to wet lab to mentoring to the point of doing it independent, what will be that roadmap?
So how we train our fellows is we start with a simulator, and it's a mechanical simulator that actually focuses on transoral outlet reduction, TOR, right? So, and it has 12 holes, and they have to do a reverse purse string, and they keep practicing on that until they can do that reverse purse string under duress. And I think Sai will be talking about that later. When they become good enough to do that, and we also do some ex vivo tissue models doing actual ESG pattern as close as we can, then they're ready to start doing actual TOR procedures. Now, that reverse purse string is a harder procedure than an ESG. However, it's a lot quicker, and it's really hard to hurt someone with that procedure, right? You're in a nice kind of a safe area to suture in the gastrojejunal anastomosis. So once they've been able to do some TORs, then we actually introduce them to ESG. And we just have them do the easier parts first, right? Some of the reinforcing sutures and running sutures. And as their skill set develops, they start doing the U stitches and then eventually progress the entire procedure. So that's kind of how we do it. We have the luxury of having our fellows trained for a full year, but honestly, this kind of protocol has helped us get them independent very quickly. So my fellows, by this time of the year, I just kind of sit in a chair and watch them and, look for something they can possibly do wrong.
Great. Usually, there will be a number of cases that you will say, well, I can be on outside the OR or at least in the OR, but not scrub or so. What would that number be for your fellow or for somebody starting?
So, with really good simulation work, I think it's reduced the learning curve, but I think we're still, Reem Shirai had a learning curve study where I think she had a number of even up to 50, where it really takes a good number before someone's truly comfortable. And I think with my development, again, it was very early on. I think it does take a good number where you don't need someone else really around, right? Where you can just do this procedure, and if you run into a problem, you can handle it and it's going to be fine. And the exact number really depends on the person. Honestly, I think if you have good endoscopic skills and you're an advanced endoscopist and you're comfortable, the number is going to be lower than someone that's a basic scientist who does fatty liver, who decides they want to start doing it, or another person that hasn't really done therapeutic endoscopy. So I'm kind of reluctant to give an exact number, but I think that is a little different for every person. And you're probably, if I had to guess, you're probably, to get comfortable, you're going to be probably between 30 and 50 cases at least.
Leave it for event. Do you want to ask a question?
Oh, sorry, Asante. So,
No, it's sorry, Bruno, you can go first.
Mine is very, very quick, as I'm being trained on ESGs, and I almost felt going back to where I started doing gastroscopy and getting lost here and there. One simple question is insufflation of the stomach from a complete, neophyte in ESGs. I understand you're saying if you want the top stitch in the fundus will be the highest risk one because the fundus is thin, and I imagine that the pressure, the insufflation of the stomach will probably reflect even more the challenges up there. Any advice?
That's a great point. We certainly use CO2 while we're doing the procedures, and there's a new endoscopic insufflator device that you can actually very accurately set. It's out of Ireland, and it maintains pressures pretty decently. However, usually what I use is I have an old-fashioned regulator, like a wall regulator for CO2, and I can dial it in liters per minute. So I can go down to 0.5 and I can go up higher if I want to. And I find I'm much more precise with controlling my insufflation with that. And if you have a Neptune system, you can control your suction and balance it nicely. I feel that really makes the procedure more efficient because you want the stomach soft. You don't want it stretched out. You want it nice and soft, but you got to see. So you got to find that nice balance. So the things that I do is I use that regulator for my CO2. You tune in your suction as well. Make sure you have good fresh buttons on there that work. And I think just keep the stomach soft. And if it starts stretching, just be aware of that and make sure you bring it back to that soft state. And I think that also will minimize the size of your capnoperitoneum.
Okay, so if there is no more question, I think we can introduce Bruno. Any more questions from? So we'll go ahead, Bruno,
Yes,
to introduce. Yeah.
Asante, please go ahead. I know you've got a question.
Thank you very much, Bruno. Thank you, Professor Thompson, for an excellent lecture. I think that was very practical, and I think it really showed, the actual good, the bad, and the ugly. My question I want to ask, and perhaps you would probably give us an answer to that, is does all training have to take place in a high volume center? And is there a place for training in low volume centers to achieve equivalent proficiency in the ESG?
Wow, yeah, that's a tough one, right? If it's a low volume center, how do you obtain proficiency? And I'm hoping our subsequent speakers will be able to answer that for us because I think that's a point worth discussion. It's a hard one, yeah. And I think it's going to take all of us to figure that one out. That is the question of the day.
Thank you very much, Prof.
Thank you.
Well, thank you very much for the great talk, Professor Thompson. Well, it's a great pleasure now to be able to introduce Professor Silvana Perretta, who is Professor of Surgery at the Department of Digestive and Endocrine Surgery at the University of Strasbourg in France, Director of Education in Strasbourg of France, and also Vice President of the very well-known IRCAD Institute in France that I had the pleasure of attending several times. Professor Perretta, the floor is yours.
Thank you, Bruno, and thank you for the invitation. Thank you for pronouncing my name correctly. That's very nice for once. Chris, I'm a little bit disappointed because you always get the cool titles. I am going to talk about the most boring thing on earth, dry and wet lab model simulation, and Sergio Leone was Italian, so I should have got the spaghetti Western one. But with no further ado, let me answer the question from Asante. So what do you do when you have to train in ESG, and especially when you don't have a high volume center? How do you maintain the level of skills necessary to do a correct in a good looking procedure? So Chris mentioned learning curve, and we didn't plan that, but this is actually the numbers that you're looking at when you're starting to learn ESG. To gather technical skill outside the clinical environment, I think that 7-9 cases, if you already had a little bit of introduction to suturing, it's okay in order to place the stitches correctly. That's a totally different thing, as Rim Sharaya has shown, than to gain the absence of outliers, which means reaching good quality outcomes and good safety outcomes. So it does take a few cases, more than 50 for sure, to get there, but it's teachable and you can learn it. What I'm going to talk about, I'm going to talk about dry models, and I like to spice it up a bit because just talking about an ex vivo stomach or a piece of rubber, I didn't think it was exciting enough for the audience. So I'm going to take the dry, interpret it also with data and with video. So how do you do video-based training without overlapping with manual, of course? And then we're going to go on the hands-on part in the lab with dry and wet model. And then we're going to explore a little bit simulation and some data-driven methods in order to personalize and improve the results of what you are doing. Chris said it very well. He set the pace. You have to know your device. It doesn't matter if you're using which kind of generation you're using, if you're using the first generation or if you're using the S6 device, you have to dissect the instruments and really know how it works. This is very, very important if you have to troubleshoot, but it's also very important if you want to know and understand how the procedure works. And I'm the kind of person that never reads the instruction on any device. I literally plug off any electronic device and plug it in again without reading how it works. But with this device, if you look at the drawings and if you understand the schematic of how it works, it will really simplify your life. Be aware also, this is a surgical needle with a surgical suture, a 1.5 curve needle. It's very powerful, but it could also be dangerous if it's not used correctly. The needle and the helix, because it can go through the gastric wall. So you have to understand how to use it and how not to use it. Like any device, I'm a surgeon, like any surgical device, you have to know how to put it together. There are two systems, so you have to know how to install it on the scope and how to detach it from the scope safely. This is not only because it's important to troubleshoot, but it's also important to preserve your scopes, because if you don't use it properly, you can also damage the scope, which is it can cost also healthcare money. For the S6 device, this is even more important because the device can be mounted on any most single channel scopes. It's a little bit tricky to adapt it to the different scope, and I would really encourage every single surgeon or endoscopist, any single operator to try to do it yourself in order to find the position that works best for you. This is my fellow Pietro, who is putting it together with me, and he's much better than me at doing that. Before you get to the OR, there is something, and to get even to the lab, there are some basic information that you have to understand. Play with the anatomy. The anatomy changes if you're doing this procedure with the patient supine or with the patient in the lateral position. We were talking about safety before. I think safety starts with the knowledge of anatomy and how anatomy is modified by the procedure and while you're doing the procedure. If you're starting, of course, the patient is going to be intubated with or without an overtube. That depends on what you're using. You want to use CO2, as Chris mentioned. If you're lucky enough to have the EVA device from Pagliara, even better. But look at the CT scan that were taken in a supine position on the left lateral decubitus. If you're in the left lateral decubitus, I don't know, Chris and the others, how you do this procedure, but if you're dealing with an obese patient, everything becomes packed in the left hypochondrium. So for those who are not familiar with surgical anatomy, and a lot of GI are not flexible surgeon as Chris is, or Baram or Rim, they have to come to the OR and at least look at the anatomy. In any high volume center, you have bariatric surgeon go and take a peek when they're doing a sleeve gastrectomy, understand the relationship and the landmarks between the gastric fundus or the stomach in general, with the spleen, with the short gastric vessel, with the pancreas, with the splenic artery, the left gastric artery, so on and so forth. And this is extremely important because adverse event, as Chris mentioned, can happen. And if you don't know the anatomy, they are more likely to happen, especially if you don't master the technical steps of the device. And that was an example of a inadvertent anastomosis with the gallbladder. So look at videos. They will help you. They will help you understand which are the landmarks. They will help you incorporate in your brain the technical maneuver better if you have the inside part and the outside part, so you can look at how the operator positioned themselves with respect to the patient, and you can look at their hands too. So landmarks are important. You can learn this also on a video, and there are very nice videos that are out there. This is just one that we did showing what are the starting landmark, the incisor angularis, but also looking on how you can simulate the path using a special simulator that you can do when you are performing this procedure, and what kind of shortening and volume reduction you can achieve. We very recently looked also at the boundaries, the legal boundaries, if you want, the safety boundaries, the go and no-go zones with EUS. This is something that I understood it's more easy to understand for some GI because they're used to do EUS, and you can really show them what are the neighboring structure that they should avoid when they're doing this procedure. And I think it's very interesting. In here you can see the gallbladder, and you can see the pancreas, and you can see very clearly also the spleen and the liver, etc., etc. Where to start? We talked about technical point. Chris was mentioning that sometimes at the beginning, the most difficult thing to do is really to understand how should the gastroplasty look like, how much you should reduce the outlet of the stomach, the pre-pyloric area, how much. So really adding some objectiveness and some science to just, okay, do a U pattern, a Z pattern, a W pattern, because that is very confusing when you're starting. Also, where is the final landmark? Where do you stop? Because preserving the fundus is a very generic term. So we establish our own landmarks. When we pull back and when we don't see the fundus anymore going back into the stomach without over-insufflating, this is also very important. You're done with the procedure. So those are all things you can learn dry, just looking at the videos, and there are multiple videos that are out there, and they're very nice and very didactic. Now, once you have learned this first part, you go to the lab, and you don't need to go directly in vivo, but you can learn a lot in ex vivo model. You can learn a lot on a piece of silicone or in an ex vivo stomach, and you don't have to go in vivo or, for God's sake, into a patient if you don't master the technicality of the device. It's just like driving. You cannot drive safely if you're constantly look at your pedals or at your gears. You have to look straight ahead, and this is exactly the same thing. So a few labs are definitely mandatory, and again, no need to go directly in the animal, but I do think that the in vivo model is important. Why it is important? Because there are a few things you cannot learn when you are in vitro. You cannot learn to introduce the device correctly, and one thing that Chris did not mention, but I will, is that in the S6 device, very often you don't have an overtube, and you cannot, depending on what scope you are using, you cannot place it. So you really have to understand how to be extremely delicate when you're introducing the system, because it's an over-the-scope system, might be bulky, and you really have to work with the anesthesiologist and work with the team to introduce it safely. Bleeding and hematoma, those are things you can learn how to deal with and to cope with in the in vivo model, and has that little bit of adrenaline that is always useful when you have to master a technique. So you learn how to deal with stress. So it's going to be my last step before you can actually start doing this in the patient when you're judged to be ready for it. Key steps, all of these key steps you have to know before you go into the patient. So mind the pharynx that with the in vivo model, get the landmark straight with the videos, mind the difference in gastric thickness. Also, you can watch with the videos. The antrum is, and the body are much thicker than the fundus. You have to learn not to push the ellix into the gastric wall, otherwise you'll fetch other things and it will bleed. Bring always the tissue towards you. That is probably the most important safety mechanism. Orient the tissue perpendicular to the jaws. Do not cross the tissue, flush the channel. So all the basics, really technical part you have to master before you go to the clinics. And then you can use simulators. This is a simulators that we built together with Insimo, which is a startup company here in Strasbourg. And what we wanted to achieve with this simulator, which is a dry model, of course, we wanted to show what happens inside that 360 degree when you're performing this procedure. Here with the simulator, you have the ability to test a pattern and to test how this particular pattern is going to work in restricting and shortening the stomach. Not only that, but also what are the adjacent organs that you're going to interact when you're suturing. And you could also make it patient specific and understand not only what is a pretty ESG, but what is a functional ESG and what is a personalized ESG for the patient. You could also personalize the learning curve. We all learn differently, and we all have weakness and strength, a strong point when we perform a procedure. This is true not only for ESG, it's true with any procedures that we do. And this is a maneuver which Manuel likes a lot. He calls it the torero maneuver. Is a maneuver that you do in order to grab the tissue, to bite the tissue perpendicular to the device, or the device perpendicular to the tissue. And on the left side, you see Manuel's curve, which is very nice and smooth. On the right side, you see my fellow Pietro curve. And this is the very first procedure he was doing. It looks like a 2-year-old drawing. He now does it very nicely and is more towards the left side of the screen. But there are devices that allow you to do motion-based training. And this is very important. In order to democratize the technique, we have been working on developing plug-and-play simulators that will allow you to train at home, to master the basic endoscopic skills. You plug the simulator into your computer, into your laptop, and then you have a 3D hardware piece, which is the replica of a scope. And then with this, you could also practice together with the other simulator. You can practice this procedure at home before you get to the lab, in order to accelerate the learning curve and probably retrain if you haven't done a procedure in a long time. You could also use artificial intelligence to review your videos in order to establish a video bank that will allow you to correctly assess the fingerprints of every single operator. Why is this important? To avoid outliners, in order to accelerate the learning curve, to prevent complications from happening. And I just want to remind you that Apollo has a registry, a European-based registry, that will allow you to compare what you're doing with the others operators. So do use the registry. It's very important. So if we can personalize training, we can identify what are the weak point of every single operator in order to really orient the training to the weak point instead of just telling them this is the way you should do it. And I'm sure that this is something that will make a big difference in the future for all surgical and endoscopic training. And then I just want to finish the talk with a little bit of science. I think that now we are in 2023 and we have to understand what the suturing that we're doing in the stomach does to the function of the stomach itself. We had decades where we were doing things trying to replicate what was working surgically without understanding it, and just because it looked the same or the procedure was named the same. I think it is very important to understand how we are modifying the gastric structure and the gastric function. And this is possible today using MRI, dynamic MRI. And I know that Bahram is also working in this field. And I hope that this will shed a new light into this procedure and will make it even more popular and effective. Thank you very much.
Dear Silvana, as Rim is not here, I may ask you the first question. And first of all, congratulations. You are really a true professor, a teacher. Really, it's enlightening always to listen to your presentations. It was really, really fun. As you said, you personalize teaching. I want to ask you a very political question. Do you think that teaching in ESG is dependent on which specialty you are coming from?
Well, I, as usual, I'm not going to use the politically correct way, or I'm just going to say what I think. And I know that, Christine, you asked me this question because you know that. I think that we all learn in a different way. But here we're talking about a suturing device. And here at ERCAT, we train about 7,000 surgeons every year. I would say that so far I train more than 680 surgeon and endoscopists and gastroenterologists in surgical endoscopy. I think it really depends on how you're comfortable with interventions. A surgeon has a harder time navigating the stomach at the beginning, but picks up the technicality of the device immediately. After the first lab, they are autonomous in manipulating the device. The GI that are not Chris Thompson or Bahram or Rim, they have to practice more with the device, but they have an easier understanding on the endoscopic landmark. Now, with that being said, I think that you have to have an inside-out view of the stomach, because this is a surgical flexible procedure. So again, you can reach the same level of expertise, but there are things that are a little bit different. So typically, with somebody who has never done endoscopic suturing and comes from the GI, I would spend more time really with the dry manipulation of the system. With a surgeon, I would spend more time insisting on, being very careful and using the right landmark inside, but then they are more at ease in general with the 3D anatomy.
That's a perfect diplomatic answer, and I think this also shows us the way to visceral medicine and not dividing the world into surgery or GI, GE. So thank you very, very much. And I think who will ask you the next question? It's Professor Al-Kattani.
Yes, thank you so much. Thank you, really, Silvana. You did an excellent presentation. And it shows how much we can do, training, measurable, and really with specific objective, and a lot of tools in our hand nowadays, especially in endobariatric, where we can improve the learning curve and also expedite it. where do you find it most difficult? Because honestly, I usually look to the system itself, the intuitive, I like the example you said, you cannot drive a car while checking where to go. I mean, whether you step on the right or the left or whatever. So where do you say it most important and most difficult for the learner? Is it the system itself to get acquainted and intuitive by the upper stitch system itself? Or is it the orientation in the stomach, right, left and right, and so on, and the symmetry of the structure? Where is the most difficult when you teach the people? I find in each part there is difficulties, but what is the most important, you think, for the learner to master first? We know the system, but inside the stomach, how is it important in your mind as difficulties?
I think that you described it perfectly. Of course, if you cannot drive a car, you don't have your driving license. But once you have your driving license, you have to know the streets in order to get going with your car. So I think are both. First, of course, you have to master the technical part. Otherwise, you wouldn't, in my opinion, shouldn't even be touching a patient if you still have trouble understanding the device. And for God's sake, don't do it with 4 hands, because that's just a mess. You have to be capable of doing all the procedure by yourself. But then is the orientation, is the landmarks, and also how you not only do a pretty suture, but a suture that's going to hold. So how do you get at full thickness bite? Where do you precisely position your stitch? And also, how do you play with insufflation? Because if you over insufflate, your landmarks are gone. How do you do all these things? And this, I think, it's something that you learn watching procedure and being proctor. And I think Manuel and the other speakers will explain this a little bit better. There are some things that you really learn in the OR. Even the click that the device does when you have a good full thickness suture. These are sensory, I would say, awarenesses that you learn while you're doing, and you always learn even when you have 200, 300 cases, 400 cases. You always try to improve yourself.
Absolutely. And also, I was lucky to some cases. I show some videos where I can monitor from outside, inside the abdomen, doing lab poly, and for example, and ESG. Where you can, is the distance is very small. As you say, the anatomy around you, you can go to the abdominal wall, you can go to the spleen, you can go. So you have to be very careful in your helix, how far you go, distension of your stomach, feeling, as you said, you must feel the wall and how far you are. If you are really feeling it's difficult or there's a resistance, you mean most likely you are going outside the gastric wall. You showed some figure, which is very important, the volumetry. How much the best things in your mind or in your measurement, the volume you can get, and you will get you the best, let us say ESG. What is the volume if you did some study on that?
We are still in the process of studying, and it is very complex. Very, very complex. And I think everybody is looking at it, but nobody is coming yet with a definitive answer. Why is it complex? Morphology is different, physiology is different, and it's an open system. So it's a dynamic volume. It's very difficult to study a volume that changes all the time. What we do know is not only the volume, but it's the combination of gastric emptying, which can be related to shortening, but not always, and volume. So we have done our first 20 patients before and after ESG. We're studying them up to 6 months. And I hope to be able to present the data soon, but I cannot come with a definitive number because we haven't figured out how to express that. Because there is the emptying part and the volume. So most likely it would be a formula, but not a percentage.
Okay. I think we have more question from Professor C or Asante.
Thank you very much, Prof. Pirata. I think your lecture was very comprehensive in how we train and the processes. I was very intrigued about the VR and the augmented reality that you do employ in your training. Obviously, that decreases the learning curve. But for example, a third world country like where I'm from in South Africa, something like that obviously wouldn't be cost effective. Is there any less expensive modalities that you would say would someone in South Africa, for example, be able to use other than the VR or the AR? Is something that less expensive to use?
Actually, it is less expensive. The reason why we did it, it's because it is less expensive. Our plug-and-play simulator is much less expensive than a standard simulator, which can cost anywhere between 50K and 100K. And
Okay.
our is not even a tenth of that expenses. So it is done really to democratize the technique. And the other simulator that I showed you comes also in a version that you can just log online and try it on your computer or on an iPad. So it's right the opposite. We did it to democratize the training in flexible endoscopy and potentially also of interventional techniques. So if you're interested, of course, that could be something you can use in your country.
Thank you very much.
Okay, so thank you, Silvana. Excellent presentation, and we'll move for the next speaker. The topic will be training in ESG, face-to-face proctoring, with Professor C. Pichamol. I hope I'm pronouncing the name properly, but advanced GI endoscopist and bariatric endoscopist, Harvard University, and Director of Bariatric Endoscopy Fellowship at the same university. And please, your presentation.
Wonderful. Thank you so much, Professor Al-Qahtani, and I'd like to thank the organizing committee for the invitation. Great. So I'm very excited to be speaking about a topic that's close to my heart, which is on training in ESG, face-to-face proctoring. Here are my disclosures. When we talk about training in ESG, we can break down the skills into cognitive, technical, and administrative skills. So for cognitive skills, it's important to understand not only endoscopy, but also bariatric surgery, nutrition, hepatology, endocrinology, and general medicine. When we look at technical skills, trainees need to understand the device and also the suture patterns that they're going to be using to perform ESG. And last but not least, for administrative skills, it's important to understand the business plan, infrastructure, personnel, and operations. So we're going to go through all of these. So let's start with cognitive skills. So we can break them down into basic skills such as sedation and airway management in patients with obesity, and more advanced bariatric cognitive skills such as medical management of obesity, how to use anti-obesity medications, patient selection, risk profile, pre and post procedural instructions, adverse event management, especially after ESG. We always encourage all of our bariatric endoscopy fellows to sit for the American Boards of Obesity Medicine and also emphasize the importance of how to establish a multidisciplinary bariatric program. For resources, there's several review articles that people can read to gain knowledge on ESG. There's a textbook and also multiple resources to study for the Obesity Medicine Board. Additionally, there's several courses that are focusing specifically on bariatric endoscopy that people attend in order to gain more cognitive skills. On the other end of the spectrum, there are several bariatric endoscopy fellowships, and this is separate from advanced endoscopy fellowship. For example, our program has one, Dr. Shariah has one, and you can see that this is the sample of the schedule of our bariatric fellows. So they attend 2 clinics with Dr. Thompson and me, and they have 5 half-day sessions that are focusing on suturing and plication. Additionally, we have several conferences to emphasize the importance of cognitive skills. These are Didactic Conference once a month, M&M once a month, and Complex Case Conference every other week. And for these meetings, we have multidisciplinary team members, including bariatric surgeons, dietitians, endoscopists, psychologists, and endocrinologists participating. Moving on to technical skills. So for ESG, we can break them down into preclinical setting and clinical setting. So in the preclinical setting, this is where we focus on teaching the device. the fellow should start becoming familiar with the device, including the tissue helix, cinching device, needle, and sutures. They should become automatic when to push the blue button, when not to push the blue button. Once they're comfortable, they can advance into the clinical training, where they should not be thinking about the device anymore, but the focus should be on suture patterns. Where should they place the stitches, how to do a U pattern, how to do a running pattern. In terms of resources in the preclinical settings, so the corporate or the Apollo has Apollo truck where they use ex vivo simulator. At our program, we have several mechanical simulators and also several societies are hosting hands-on courses focusing on suturing. All right, so I'm just going to walk you through the life of our bariatric fellow, Rob Tresolini. So July 1st on his day one, what did he do? So prior to his starting, we actually sent a list of readings on bariatric endoscopy to him. So he started preparing. He attended bariatric clinics and conferences. From a technical standpoint, he started participating on day one by assisting with a helix and cinching device. Additionally, he started using the suturing simulator. So here's a video of our simulator. So Chris mentioned a little bit about this simulator. As you can see, it's made of plastic, very inexpensive, and it has a hole with, it is a circle with 12 holes. So it simulates a TOR procedure. And the reason why we use the TOR procedure as a simulator, because we think that purse string is a more complex suture pattern. So you want to train with a more complex so that other patterns can become easier. So the rule here is that the fellow has to go around in a reverse purse string suture pattern and place 12 stitches around the circle within 5 minutes. They cannot skip a hole. They may cross a suture. However, if they do, they're going to get more suture tension and therefore probably will not complete the task. If they drop or bend a needle, they can start a new needle or suture, but again, they probably will not complete the task within 5 minutes. So what are the benefits here? So by using the simulator, they learn the steps of the overstitch, suture management, like how to give suture slack, this is too much tension, and also learn troubleshooting, such as untying a knot and how to prevent a bent needle. So data from our center show that fellows who participated in the simulator training were able to complete full purse string tour within the first 2 to 5 cases. And you can see that this is much lower compared to 40 plus cases for the fellows who did not use the simulator. Here's a picture of our fellow Rob on the day he passed the simulator. So you can see some mess here. So there's some Pam here. So we simulated the real life experience, right? Sometimes your hand can get a little slippery. The light can go on and off. Also, the door can open and close to simulate some interruption during the case. So it's a very, very fun test, but he's ready to go into clinical cases. So once they pass the simulator, we allow them to start sewing in clinical cases. Here's the ESG pattern that we currently use. You can see that I usually start at the incisor using the running suture pattern. After that, we do a U pattern followed by interrupted pattern medially, and then repeat the same thing from distal stomach to proximal stomach. So the first place that I usually let the fellow start is interrupted suture pattern because it's only 2 stitches, it's more simple. After that, once they master that, they can go to the running pattern. Usually it's about 6 bites, pretty simple. After that, if they do well, then they can advance to the U suture pattern where they're more involved. Additionally, location matter. Usually the distal stomach is a little easier because it's thicker. So usually I let the fellow start sewing in the distal stomach, but once you come up closer to the fundus, that is more advanced. So they do it towards the end of the year. All right, so what about training for practicing endoscopists or surgeons who have advanced skills but want to pick up bariatric endoscopy skills? So this is a different trainee population. From a cognitive skill standpoint, this is probably similar readings, attending or shadowing clinics, attending conferences, watching live cases. Next is technical skill training. So they can use simulators at outside. Usually they use ex vivo simulator. However, usually these endoscopists are busy. They do not have a year to participate and gradually learn different steps of ESG. So we have to come up with a curriculum that involves abbreviated proctored cases. So here's our experience proctoring the very first ESG in Thailand. So originally it was supposed to be face-to-face proctoring back in April of 2020. However, COVID hit. So you can see that we ended up converting it into virtual proctoring. We were told it's one of the very first virtual proctoring for ESG for Apollo. We're going to hear a great lecture from Manuel in the next lecture, so I'm not going to go into more detail. 2 years later, another hospital from Thailand wanted to establish the very first bariatric program for their hospital. So we brainstormed and came up with a curriculum that involved 2 trips. The first trip was in September of 2022. So you can see that they flew both Chris and me back to Thailand, and we had 2 days of training. So first day focused on using ex vivo simulation to train them to be more familiar with the overstitch. And then on the second day, we both performed 2 ESG cases to demonstrate the techniques and patterns. 3 months later, they flew me back for the second part of the training, and they lined up 2 cases. So for the first case, I performed ESG, and Dr. K here, who's the director of endoscopy, very skilled ERCPS, he's actually the vice president of Thai ASG. He assisted with the case. And then for the second case, he performed the case, and he was assisted by another advanced endoscopist in Thailand, and I was proctoring that. So after this training curriculum, they felt more comfortable and were ready to do more cases independently. So you may wonder, so now I've done a few proctored ESG cases, and now what? So let's look at this study. I know everyone has mentioned this study from Rinchoraya. Basically, it's a single center prospective study evaluating the first 120 consecutive ESG cases that she did. Efficiency was defined as the point on the learning curve where the procedure time started to decrease. And this was reached after 38 cases. Mastery was the point on the learning curve where the procedure time became consistent, which meant that there's no outlier in terms of procedure time, and this was reached after 55 cases. So you can see that even with proctored cases, one still needs a relatively high volume of cases to get over the initial learning curve. And therefore, it is important to be at the place with high volume, and that's where the administrative skills come in and why it's important. So when we talk about administrative skills, we can break them down into business plan, infrastructure and personnel, and operations. So we're going to go over some of the key items here. Financial plan, we always encourage the fellows to apply for a grant, hopefully to cover the initial 50 cases so that they can get through that learning curve. Additionally, everyone has to come up with a self-pay program, and at that time, try to collect the data from all the cases so that ultimately they can go to the payers and try to get insurance coverage for ESG. To come up with a self-pay program, one has to think about different costs. These include professional fee, facility fee, anesthesia, device price, liability, dietitian fee, and marketing. So all of these have to be accounted for when someone come up with a final price. What about treatment pathway? How are you going to get patients to come into you for ESG? So here's a treatment pathway for our Center for Weight Management and Wellness. So you can see that the first question is we ask the patients for their BMI. If their BMI is between 27 and 29.9, then they're scheduled to see the endocrine, the medical obesity team. If their BMI is between 30 and 35, the next question is, are you interested in bariatric endoscopy? If they say yes, they come to Chris or me, like our bariatric endoscopy team. If no, then they go to endocrine. If their BMI is greater than 35, the next question is, are you interested in bariatric surgery? If yes, they go to surgery. If not, they come to bariatric endoscopy. We then look at our data since we incorporated that pathway, and what we found was that the clinical volume and procedural volume significantly increased for all disciplines. And I want to highlight 2 things here. Number one, you can see that for bariatric surgery, the clinical volume increased by 22%, but the procedural volume significantly increased by 72%. So what does that mean? That means the surgeons are seeing patients who are, number one, eligible for surgery and also interested in surgery. So they're not wasting the clinic spots. Point number 2 is, if you look at bariatric endoscopy volume, our clinic volume increased by 158%. But you may wonder why our procedural volume increased by only 17%. So we actually are limited by the number of rooms that we can perform ESG. So it turns out that our waiting list significantly increased by adopting this protocol, and now the waiting list is over a year for the procedure. Last but not least, it's important to have essential infrastructure to treat patients with obesity. The bed, the blood pressure cuff, the scales, everything have to be appropriately sized. Furthermore, we need to work together with other disciplines, including bariatric surgeons, psychologists, dietitian, exercise physiologists, and obesity medicine experts. In conclusion, ESG training requires a multidisciplinary approach and should focus on cognitive, technical, and administrative skills. ESG training may be divided into preclinical and clinical training, with the former focusing on learning the device, usually using a simulator, and the latter focusing on learning the suture patterns, start with assisting, then performing easier to more complex suture patterns. Different groups of trainees will require different emphasis, and the curriculum should be adjusted based on trainee characteristics. And last but not least, given the prevalence of obesity and the recently approved overstitch, there will likely be an increase in the number of dedicated bariatric endoscopy fellowships, as evidenced by our bariatric endoscopy fellow, who's always so busy that he usually has only one meal a day at midnight. Thank you very much.
Okay, thank you very much. Thank you, Professor Sai, for a beautiful lecture, and I think it was very comprehensive on basically how to train within a high-volume center. In terms of being a proctor and having a trainee, let's say you're in a clinical situation, and you're in the clinical situation in the sense that you're doing an ESG, and a complication happens like bleeding, which is quite severe bleeding. Who takes over control of that situation? Is it you as the proctor, or will the trainee attempt to try and control that situation?
So thank you so much for the question. So I think it depends on what complications and also where the trainees are in their learning process. If it's early on, so our fellowship starts in July. So if it's early on within the first 3 months, usually I will take the scope and then manage that complication. But now we're about month 8 in. So usually if that happens, I actually just came out from an ESG and the helix got stuck, then I would let the fellow kind of try to untangle the helix for a little bit. If it looks like he's getting there, then he will continue. But if it looks like, maybe it doesn't get there, then I will take over the scope. So depends on the situation.
Okay, thank you.
You're welcome.
I thank you very much for, again, a great presentation, and congratulations on the training program. It's really impressive. A few questions. Do you need, about the candidates, do you need the candidate for this training to be experienced skills, or can they be basic endoscopies or have ERCP experience already before they start? That would be number one. Number two is about, once you start the training, patient selection. Being a surgeon, I'm very familiar that, patients have very different stomach in shape. So would you recommend, at least at the beginning of the training, choosing a patient who may have, a long, a drop-shaped stomach, or on the other hand, someone who has a more kind of more rounded stomach? And lastly, you did mention that there are various, everyone has mentioned different suture pattern, but I've got the impression that everyone tends to do U-shaped patterns more frequently. Why not teaching straight away the U-shaped pattern if at the end of the day the trainees will end up doing that?
All right, thank you so much, Bruno. Let me go through each of them. So the first, I love all of them. So the first question is on the trainees. So we review a lot of applications, and prior EUS ERCP training is not a requirement. We have trained several fellows who did not do EUS ERCP and is not planning on doing EUS ERCP in the future. We just have to adapt the curriculum based on their prior experience. For example, people without EUS ERCP, we may have to spend a little more time on some basic like maneuver movement of the scope. But in the end, everyone got to use that simulator and become quite comfortable with the overstitch by the time they start sewing in patients. Now, second question.
Patient selection. Oh, stomach selection.
Yeah, so I think to start out, you want to select patients who have fewer comorbidities. Those tend to be easier stomach because they tend to bleed less and they usually are more compliant, so that when you pull the tissue into the overstitch, it's easier to sew. If you pick, usually based on my experience, people with more comorbidities sometimes have stiffer stomach. So when you pull the tissue in, it might not come in as nicely. So they might lose the opportunity to like learn that pulling technique. Additionally, from a shape standpoint, the J-shaped stomach is harder to sew because it might be harder to like select where to start, and then you have the lesser curvature coming in. So I would avoid a J-shaped stomach early on in your learning curve. And
thank you very, very much. Oh, there was a third about the suture pattern, but thank you for your.
Thank you so much.
Sai, it's my turn. It's so good to see you. You are really an educational giant as well. And I liked so much your presentation and that of Silvana, because if I remember my training, and it was by chance in Boston, but not in Harvard, but at the BC week, it was, I would say 20 minutes. And I went back and, you know, I was really struggling with the tool a lot. So nowadays it's great. There are videos, there are training schedules. It's really great for people who want to start ESG. What would you say is doing an ESG really possible in each hospital around the world, or would you say it's only possible in hospitals that do have this multidisciplinary approach like you do have?
Christine, so nice to see you as always. So I believe that there should be the key components of the multidisciplinary team at the hospital who want to start bariatric endoscopy. Now, you don't need all personnel to be on site. For example, if you're missing a dietitian, then sometimes you can use a virtual dietitian. So, but at least there should be all of the components. Like you shouldn't start performing ESG without having most of the key components.
Yeah, I think so too. That's a very, very important, as you know, the technical thing is the one thing, but if you discharge the patients from the hospital, you have to give them a diet plan or whatever at their hand so that they exactly knew what to do. So thank you very much.
You're welcome.
And have a good day.
Thank you, you too, Christine.
I think Professor Asante will now introduce the next speaker, right?
Yes, thank you very much. And it gives me great pleasure to introduce the next speaker. It's a great friend of mine, a mentor, and very well known in the endobariatric world. I'm speaking about Prof. Manuel Galvão Neto. He's a scientific director at the Endovita Institute in Sao Paulo, Brazil. He's a clinical professor of gastroenterology and surgery at the Sri Aurobindo Institute of Medical Science in Indore, India. He's a head of bariatric endoscopy in Mohawk Bariatrics and Robotics, Indore, India. He's an affiliate professor of surgery at ABC College of Medicine, Santo André, Sao Paulo, Brazil. He's a flexible endoscopy committee member at SAGES and bariatric endoscopy committee member at American Foregut Society. He will be presenting teleproctoring in the ESG, why, when, and how.
My dear friend Asante, thank you very much for introduction and the kind words. And let me start telling you something. This is just a historical webinar. What we just saw is just amazing. Harris and Bruno excel themselves one more time with this program, and you see the kind of the quality of presentations we saw by Chris, by Silvana, by Sai, is just amazing how something that is so new has achieved such a level of knowledge, training, and transmission of knowledge itself is just amazing. I think we just set up the bar for the next procedure that will come. And also we counting with Christine, with Ayed, and with him here is just much more than camaradage and chevalierism that we have in IBC. And I will try to keep it up with the level with the next presentation that is about teleproctoring on ESG itself. So the text allotted to me was why, when, and how. And I'll tell you and talk to you on my own experience. And you just saw that ESG is a procedure that is very well established nowadays, very well standardized, okay? So, and the history just explained itself by the creator, Thompson, and that leads to our own experience. For the first publication that set up the name, it doesn't matter if you agree or not with the name, the publication of Abraham set up the name that we have to use, and end up with the publication in Lancet that allowed us to be approved by FDA. So up to now, it has been a fantastic journey, a remarkable one. 10 years of experience, 15 to 20% total weight loss expected. The safe, doesn't matter what you do. Even this meta-analysis, 12, 14 papers keep the same, 2 to 2.5% severe adverse event, 1 to 3 years robust results, around 40K cases the world, we see the selection of the patients. So let's go that. So the previous way of training, we just saw it brilliantly explained. One-day courses, boot camp, proctoring with technicians, MD proctoring, and even academic proctoring at a high level. And you see here pretty much of the history that we got to 2013 to 15, because we started in 2012. So we were teaching each other, learning from each other, doing multi-centric trials, have the first meetings, and you can see here. And then it got to the level that we could spread a little bit more all over the world, in Asia, as you can see here, in India, Middle East, and so, and then we got to Brazil, that we have the opportunity to establish our own way to training with one-day course, boot camp, MD proctoring after that on the trainee site, that end up on the Brazilian consensus, that even we can show that established and standardized way of training can drop down the severe adverse event from 2.5, from 2 to less than 1%, with keeping the good results. And then my personal experience, and by what most of us have to do in terms of teleproctoring, it was the COVID times. So everything stopped, and how to start, how to continue, that was a real challenge, in that we faced the wall. Everything was stopped. So we have to find the way, and the way was the teleproctoring, the telemetry, and how to do that in the right way. So we got this problem, and we got the opportunity to do a pilot. So understanding and establish the goals, defining patient selection, broadcast a procedure that the trainee was comfortable with on that, and test the connection, test the scenic, test how they communicate to each other, the level of English that it is the language that we're going to be using, present and discuss possible patients, and then has hands-on lab, didactics in a remote way, and then finally get to the cases. So let's begin in trying to explain to you what we have done. So we have a face-to-face meeting. This is Dr. Jonathan Jerez. He's from Ecuador. So we start talking. What do you want? What is your goals? How is your skills? What you have trained? Tell me your history. And then we got the, okay, you can see he was dressed in COVID times. I want you to perform a procedure that you used to. So he chose intragastric balloons, and then we set up everything to see the scenic communications and how it gonna works. Then he presented me the cases he wanted to do, and we approved the set of cases. And each one of those is not one day. Each one is a different day, a different session. And then we went to the wet lab. So you can see here, he has the device. I have the device on my side. We're able to communicate and to go to all of the things that we will be doing in a one-on-one wet lab. So after that, we decide how we're gonna do. So it runs some testings, and we decide to use the most simple tool. That is what I'm using right now, is the Zoom communications. And we got to a breakthrough because we have this delay that everybody says we're not able to proctor because of the delay, because of the internet that we let, and it's not there. We got to a point that the delay, half of the delay is causing that you would have to use, you want to use the computer to do everything. So we got to this breakthrough. Just use a video capture card, very simple one. And this cut your delay by half. Don't use interfaces, don't use nothing. So the computer that capture the signal from the tower have to be used only to broadcast. And then other simple breakthroughs, simple devices ready to use. For sure, all the patients had allowed us to do that with informed consent. We have IRB, but look at that, the major breakthrough that allowed us to do what you do. And please understand that is the last one on the right, earpiece. Never broadcast, never proctor anyone with speakers. Why? Because you're gonna break the chain of command. You communicate with the one who is doing, and this is the key to do this. So you see, I could able to see him, his hands, talk to him, and guide you all the way, and he was able to see me in an iPad. So with that, we start. And we start in a way that we can even draw with a very simple tool that is the drawing over of the picture that the Zoom has it. And we were able, and you see how comfortable I was in proctoring him, and it ended up on this publication. And these publications show us an amazing thing that I'm about to show you. Look at the learning curve in 10 cases. And it doesn't contradict what RIM have presented and other papers have presented in terms of, and even Silvana, learning curve. It's because it was a 101. So, and no one has this luxury of going home after being trained and have a 101 proctor. So with that, we could use in 10 cases, a dramatic drop on the learning curve. And after that, he was doing his cases, and we were even, then that was a major barrier. Should we be able to fix complications together? Yes. So you can see here, this is a case that 7 days after has a bleeding, and I was able to, with him, to solve that with clips during the case, and I remember it was 3 a.m. on that. And if you're listening to us, Jonathan, you will really remember this one. So you have the chin, and more than that, after he done like 20, 30 cases, and say that, okay, we're gonna have a graduation. What's a graduation? He have to broadcast to EarCard reel to our bariatric endoscopy course. Silvana was also there with us, and he has to do a live case in front of our proctors, and he passed the bar. So that's how we test this. And after that, we spread it. So name a country, we were there. Ascent, we were with you. So you see here Taiwan with Ami, Turkey, we are in Colombia and USA, so all over that. And even without even using this like simple tool that's Zoom, now we can be much more sophisticated. There are platforms, they are becoming better and better, and even centers like EarCard with Silvana, like Mohawk in India with us, we have our own broadcasting system. But look at this one I've been using, that is Nadine. She is a bright surgeon from UK that developed this whole platform. So you can see here that we start with this demo that we were able to even to us identify the path, and then we went to Rio. So I'm proctoring inside Mohawk facilities. So that is my my station. So I'm seeing the trainee on the OR. And what you're about to see is that how the trainee is on the OR. Just a second, and we're gonna move to the OR right now. And you see here, you have the regular monitor, but what is seeing that I project my hand and say, go here, go there, and I can see both inside and outside. And then the real deal. So this is me in our home in Orlando. So I get to my station and I just connect. And in India, from US to India and indoor, we can see the trainee and we can guide them into even a clinical case. For sure, we have outside a trained endoscopist to assume if everything goes wrong. But this is how we do that to test if teleproctomy will work or not. So with that, I do conclude, and I think we can move to the questions. And again, thank you once more for this opportunity. That and great to see IBC excelling itself again.
Manuel, thank you very much. You know, as always, absolutely inspiring and terrific, your presentations. The first instinct reaction to your talk is, when can we start? But my second reaction is, hang on a second, for sure, there must be a validation from a medical legal point of view that telementoring is equal to one-to-one, you know, mentoring. Are we there already?
Indeed, we are. I just show you. It's published. Go ahead. So there is some barriers for sure each country. So in US, you have the HIPAA compliant. You have to be HIPAA compliant. Zoom has a very expensive license that can be HIPAA compliant. Proximity and all the platforms, they are HIPAA compliant. So they are compliant with the preservation of the patient's data to not be exposed on that. In that specific case, we didn't have it, but it was under IRB because of COVID and patient's consent, it was approved. So it's there and it works. So it's really validated, and not just on ESG, it's being validated all over the world on that. And with the 5G coming to reality, it's going to be even, you can do more things remotely, robotically, and things like that. So you know what, my friend? Go for that. You see here, Silvana have done it, SIG have done it, Thompson have done it. We were able to help so many people during COVID, and still we are able, and even Inc. here, and I never saw a single opportunity that the patient's life was in jeopardy if you do the correct protocol. What I don't agree, what I don't like, and I think you are there, is that that someone jump on your OR to proctor the case just right away. So that's not the right way to do it.
Thank you very, very much. Christine.
Thank you, Bruno. Manuel, fantastic. I mean, this shows that COVID does not only have bad sides, but also one good side, connecting the world artificially. So this is really, really, really very impressive. My question is, how did you find those platforms? Did you search by yourself after those platforms, or were they offered to you? Because this is really a very good tool for teaching.
Basically, it is spreading, Christine. So you see, in UK, the NHS now embrace it. So most of the hospitals are having that. So it's something that is really, really spreading to that. And also, you can connect to them, and all of those platforms, they'll get back to you, and you can establish in your own center. And depending, and they are very like how can I say, 101. They will identify your needs, and they will build that for you. And meanwhile, if you just wanted to jump on that, Zoom has a HIPAA compliant license that you can go for that, and it's very, very easy and very cheap on that.
Absolutely cool. Just one last question. Did your trainees, did they feel secure with you just teleproctoring?
Yes, they do. Cool. You can ask for Hank here. He was there.
No,
and
absolutely.
And it depends on establish a relationship. So it's like proctoring 101. It only goes well when you establish the relationship with the one you're going to train. establish the pathway and the confidence to win one-on-one. And it can take 1 session, 2 sessions, 3 sessions, but you only can move forward, I think, when you establish this confidence. And you just touch it. You just really nail that. Without confidence, you should not move forward.
Extremely impressive. Thank you so much.
There is a question from Professor Thompson and then a question from the chat.
Manuel, love your lecture there. Thanks very much. You've obviously trained more than anyone in the world. You've trained more people in ESG, and I'd like to know, we have so many more people yet to train, right? There's just so many more to train. What do you think the ideal paradigm for that will be? Can it be just fully virtual? Would you prefer to have at least one kind of proctoring session? Kind of what do you see the best structure for training the masses at this point?
That's a really millions and millions of dollars question. I think what I saw you from SIG, that's the key. Tailorize. If you ask me what is the best, is one that we had proven in Brazil and we had published that. So it's 1-day course, know the person, get them to the boot camp, understand their skills and analyze their skills on that, didactic live case, and then proctor them on their own facilities. That will be, to me, with 3 cases and see how they do, and then send the non-MD proctoring to more 4 or 10 cases, because with 10 cases, they were able to do it, and 15, they are comfortable, 13, they get to master that. So I think that's gonna be the way, but it's not the reality. And to train masses, I think what we saw from your service, you and SIG, I think in what Silvana is doing, she's training masses and very effectively. And the thing is, who gonna go after that and do the cases when you train masses? So that's, we have to find an algorithm to follow those people to see how they're gonna do, because it's not enough if they do one course or not, they should do that. They can come together or we can monitor that. But still, it's an open question. I don't have the capability to answer you at once.
Okay. I think we're coming. And any other questions? Oh, sorry, the questions from the web came actually from our president, Tom Rogler, and is actually a question that any surgeons and doctors should ask about ESG. Is there any role for performing ESG under laparoscopic guidance? I see Professor Peretta.
Yeah, no, I might answer that. Being from a surgical point of view, I think that the answer today, I think, and everybody on the panel might agree, is today, after the experience that we have, after the data that we have put together, the answer is no. I don't think that is necessary. That being said, I think it was very useful at the beginning to have some of those images, because it's really made us understand how the device was working and how powerful the device was. But I don't think that there is any role today, unless, of course, you run into trouble. And if you do this with a mixed team or in the OR directly, and you're a surgeon, it's always nice to have somebody that can take care of a complication, even though they're very, very rare.
Wonderful. Well, thank you very much for this clear answer. And Professor Al-Qadani, do you have any questions for Manuel? Seems like he doesn't. In that case, we are coming to the end of this absolutely interesting webinar on the ESG. I personally would like to thank every single individual, every single speaker, Professor Peretta, Dr. Steer, Professor Singh, Professor Thompson, Dr. Asante, and Professor Neto for your contribution, and a personal thank you for the effort you put in the educational and about ESG, and also in driving this technology kind of evolution. And having said that, I will pass the word to Professor Ortiz for the closing of the webinar. Thank you very much again.
This has been an IBC Oxford University Hot Topics and Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics and Surgery, subscribe to our IBC YouTube channel and follow us on our social media platforms. Don't forget to mark your calendars as the 4th IBC Oxford Congress is being held from September 18th to the 20th of 2023. For more information, go to ibccongress.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
The endoscopic sleeve gastroplasty is a non-invasive endoscopic procedure designed to reduce gastric volume. This animation provides an overview of the latest technique. A coagulation device, such as the argon plasma coagulator, is used to mark the anterior and posterior walls of the stomach along the greater curve. This creates a guideline for the first outer row of sutures. The first row of full-thickness stitches is placed from distal to proximal. A running triangular suture pattern alternates from anterior wall, greater curve, posterior wall, and is repeated for 5 to 6 bites. The anchor is then released and the stitching sequence is cinched tight. The triangular pattern is repeated. A total of 5 to 6 triangular running stitches are repeated in this first row. This suture pattern is designed to maximize the reduction in stomach volume and foreshorten the greater curve. A secondary inner row of interrupted or running stitches is placed following the lesser curve to create the sleeve effect. These plications extend up to the gastroesophageal junction just below the Z-line.
Prepare to load the needle body by closing the needle driver handle. Advance the anchor exchange catheter until the anchor clicks onto the needle body and will not advance further. Press the blue button on the anchor exchange catheter and pull back approximately 1 centimeter to disengage the anchor from the anchor exchange catheter. Open the needle driver handle. Advance the tissue helix through the 2.8 millimeter device channel. Push down on the blue cross button to expose the helix. Using forward pressure, turn tissue helix knob in the clockwise direction to capture tissue. To ensure a full thickness bite, maneuver the scope such that the tissue will cross the needle guard. Pull tissue until it reaches the scope. Close the needle driver handle to pass the anchor and suture through tissue. Advance the anchor exchange catheter over the anchor until the locking mechanism engages. Without pressing the blue button, pull the anchor exchange catheter back to disengage the anchor from the needle body. Turn the tissue helix counterclockwise to release from the tissue and pull the blue cross button to retract helix. Finally, open the needle driver handle. Repeat steps for additional full-thickness suture placement.
Huh? Still?
To prepare for cinching, extend the anchor exchange catheter approximately 3 centimeters past the end cap. Press the blue button and pull back on the anchor exchange to release the anchor. Remove the anchor exchange catheter from the 3.3 millimeter device channel, leaving the suture in place. To load the cinch, thread approximately 3 centimeters of the distal end of the suture through the gold suture loading loop. Pull the gold tab in line with the catheter until the suture has passed through the peak collar. While holding slight suture tension, insert the cinch into the 3 millimeter channel of the device. Advance the cinch catheter until it extends approximately 3 centimeters past the overstitch SX end cap, targeting the placement of the first bite. While holding the cinch catheter in place, apply tension to the suture with small increasing increments of force. Care should be taken not to pull the suture too tight, resulting in breakage. Once the desired amount of tension is reached, open the cinch handle with the palm facing down. This will release the safety mechanism. Deploying the cinch is completed in 3 stages. Stage 1. Squeeze the cinch handle with one hand to pull the PEEK plug into the collar and lock the suture. Stage 2 of deploying the cinch will require 2 hands. Continue to squeeze the cinch handle to advance the beaded rod through the PEEK plug. Finally, continue to squeeze the handle to activate the suture cutter and release the PEEK collar and plug. Remove the cinch and suture from the scope channel.